Good afternoon, everyone. My name is Taimur. I am one of the Jackson Memorial Hospital internal medicine chiefs, and it's my honor to introduce our first speaker for today's Grand Rounds, Dr. Marcella Kaddoura. She is an assistant professor of medicine in the Division of Myeloma at the University of Miami's Sylvester Comprehensive Cancer Center. She earned her medical degree from Wayne State University School of Medicine and completed both her internal medicine residency and HEMONC fellowship at the Mayo Clinic in Rochester, Minnesota, where she also served as chief fellow. She was interested in myeloma early on, and Dr. Landgren recruited her to join our program in Miami when she graduated. She's been able to develop a strong translational research portfolio as part of the Myeloma Institute. She has gained world-class skills in computational oncology, and she has dissected molecular underpinnings of myeloma pathogenesis as well, as mechanisms of treatment response and resistance focused around the BCL2 pathway. She has given numerous oral presentations at larger meetings, including ASH. She was awarded the Sylvester Comprehensive Cancer Center K-12 Award last summer, and she has expanded her work on BCL2 inhibition in myeloma. Her most recent work was recently accepted in Nature Genetics, and she will share with us today some of the results and link it to a clinical case. We are very proud of her strong translational work. Please welcome Dr. Marcella Kaddoura.
Thank you so much for that very kind introduction. I'll go ahead and share my screen. Okay, so thank you guys so much for inviting me to be a speaker at today's Department of Medicine Grand Rounds. It's really such an honor to be with you all today, and I hope you get some key takeaways from this talk. I have no disclosures to report. So the objectives for this talk are to review the diagnostic criteria and relapse presentation of multiple myeloma, to understand the clinical and molecular significance of the translocation 1114 subset in multiple myeloma, to describe the role and limitations of the use of venetoclax in the treatment of T1114 myeloma, and to explore molecular and genomic mechanisms of venetoclax resistance and the value of molecular and genomic profiling in guiding precision therapy in this disease. So we're going to start with just a brief background into multiple myeloma as a disease. This is a hematologic neoplasm that involves the plasma cells, which are the terminally differentiated B cells, whose normal role and function is to create and secrete antibodies to help fight off infections. Multiple myeloma, we know, is a several decade-long process and pathogenesis, starting with the first post-germinal centroclonal plasma cell, which then enters the MGUS or monoclonal gammopathy of undetermined significance phase, which can then enter the slightly more aggressive precursor stage, smoldering myeloma, and some of these also can then go on to progress into the active classical multiple myeloma disease that requires treatment. And so, like I said, this is a several decade-long process, and we've identified several drivers in this disease. And some of these drivers are known to occur very early at the onset of tumor evolution, and these include hyperdiploidy and canonical IgH translocations, while some other drivers like MYC amplifications and other copy number aberrations are known to occur later on in disease pathogenesis. Chromosome 1q gain and amplification is an important feature in myeloma because it carries prognostic value, and this is a genomic feature that's been seen to occur both early in disease, potentially as a driver, and then also later on in disease and even after treatment. Multiple myeloma accounts for approximately 10% of all hematological malignancies, and it has a median overall survival of roughly 8 to 10 years. Now, unlike the other hematologic neoplasm counterparts, such as leukemia and lymphoma, myeloma remains an incurable disease, and that's largely been attributed to its incredible biologic heterogeneity, where we continue to rely on histopathologic diagnosis. However, we know in clinic and in the lab that not all patients behave the same, and not all patients respond to treatment in the same way. When I think of the myeloma workup and the diagnostic workup, I consider kind of two big categories in my mind. And one is patients presenting with myeloma-defining features, and patients presenting without these more classic myeloma-defining features. And so the myeloma-defining features I'm referring to are the features in the CRAB criteria. And we've studied this. We know these features from med school and throughout our medical training. And we know that if a patient presents in clinic or to the hospital with one or more of these features, myeloma should be on the differential. And these include hypercalcemia, renal insufficiency, anemia, and bone lesions, and these would be lytic bone lesions. And so a patient presenting with one or more of these, plus a bone marrow biopsy showing 10 or more plasma cells accounting for the total cellularity in the bone marrow, would qualify and count as a diagnosis of multiple myeloma. In contrast, patients who do not present with these CRAB features can be diagnosed with myeloma, but the numerical thresholds for some of these criterion change. And so patients getting a bone marrow biopsy for a different reason to investigate, like a nonspecific cytopenia, revealing 60% or more plasma cells, is enough to diagnose the disease. Or if a patient has an involved to uninvolved serum free light chain ratio of at least 100, with the involved free light chain ratio being either kappa or lambda, having an absolute value of 100 milligrams per liter. Or a patient can have more than one focal lesion on MRI at least 5 millimeters in length. So this is another way to diagnose this disease. So going into our clinical case, we have a 68-year-old male with a history of multiple myeloma, and he was diagnosed 3 years ago. And at the time of diagnosis, he presented with a few things. So we always get a serum protein electrophoresis if we're suspicious of myeloma, which will measure the monoclonal protein level. Normally, this is supposed to be 0, but this patient had an elevated monoclonal protein level of 3.5 grams. In addition, we get a CT or PET or MRI skeletal survey to look for lytic lesions. This is one of the baseline tests that we order, and this patient ended up having lytic lesions throughout his axial skeleton. And so these two features are strongly suggestive of myeloma. However, this would not be enough to diagnose this patient yet as having myeloma, and definitely not enough to start treatment. So we always have to get a bone marrow biopsy. This is a picture of what these lytic lesions would look like on imaging. And so we'd see these kind of hollowed out areas or holes in the bone. And these are not so much driven by the clonal plasma cell process, but more so by the inflammatory process that these plasma cells induce through like interleukin 6. So this patient went ahead and got a bone marrow biopsy showing 50% clonal plasma cells. We always send tissue for what we call cytogenetics and FISH testing, because we know that there are some genomic changes in myeloma that carry prognostic relevance. And so this patient ended up having a translocation 1114 between the cyclin D1 gene, CCND1, and the immunoglobulin heavy chain region on chromosome 14. So because he had a myeloma-defining event with the lytic lesions and over 10% clonal plasma cells in the marrow, this is enough to now diagnose him with multiple myeloma. And he ended up receiving 3 lines of treatment. We started him with the classic quadruplet regimen with daratumumab, which is an anti-CD38 monoclonal antibody, with a proteasome inhibitor in the form of Velcade, an immunomodulatory agent in the form of Revlimid, and dexamethasone. We usually employ dexamethasone in most of our myeloma regimen backbones. Because this is an incurable disease, these patients inevitably will relapse from treatment. And so his next line of therapy ended up being KPD, which is carfilzomib, another proteasome inhibitor, pomalidomide, another IMiD or immunomodulatory agent, and dexamethasone. And then after he relapsed from this treatment, we went ahead and gave him one of our very exciting and more new FDA-approved therapies, BiTE therapies, which stands for a bispecific T-cell engager, in the form of teclistamab. So, like I said, because all of our patients relapse, we're always monitoring these patients for relapse, and this can present either in the blood and or with symptoms. And so this patient, while on teclistamab, came into the clinic and was complaining of new bone pain and fatigue. And so because he has known lytic lesions that were present at the onset of his disease, this is certainly a red flag for relapse. And so we went ahead and did the relapse workup with a CBC that showed a worsening anemia with a new hemoglobin of 8 from a baseline of 10 on treatment. A monoclonal protein now up to 2 grams. We always compare the monoclonal protein to the lowest level or nadir while on the most recent therapy. And for him, his nadir had become undetectable or 0, achieving a complete response to treatment. And so this is definitely concerning for relapse. And because he was complaining of new bone pain, we went ahead and repeated a CT skeleton and found new lytic lesions. So this all definitely is consistent with disease progression. And now we have to consider, what are we going to treat him with next? We have a few options. We can combine an alkylating agent with bortezomib and dexamethasone, such as cyclophosphamide. We can use a selinexor-based therapy with pomalidomide. We can use a different type of cellular therapy or immunotherapy, like a bispecific T-cell engager targeting a different plasma cell surface marker, like GPRC5D, or we can even consider CAR T therapy, which is an effective but a slightly more lengthy process. And then, of course, we always consider our patients for clinical trial enrollment. And so these agents or these regimens are all nonspecific therapies. And then we remembered that this patient has a translocation 1114. And so this is particularly important in myeloma because this is a targetable genomic driver. So translocation 1114 is the most common IgH translocation in this disease, and it's seen in up to 20 to even 25% of newly diagnosed cases. And this involves the juxtaposition of the immunoglobulin heavy chain region on chromosome 14, which is a highly active area of the genome in myeloma, next to the cyclin D1 or CCND1 gene on chromosome 11. And so what you have on the derivative chromosome, you have a highly active region here next to an oncogene that can drive increased expression of that oncogene and therefore oncogenesis and serve as a driver in this disease. The other thing this derivative chromosome in this translocation will do is it increases the BCL2 dependency within the BCL2 pathway. And so this is a schematic of part of the BCL2 pathway where we have the BCL2 regulator or protein serving as a pro-survival protein. And it does so through binding to and sequestering the pro-apoptotic protein BIM. BIM's normal function is to go ahead and activate BAX and BAC, which then go on to induce apoptosis. And so that is how BCL2 inhibits apoptosis, by binding to and sequestering BIM and other pro-apoptotic regulators in the pathway. And so when we consider venetoclax, venetoclax works as a BCL2 inhibitor. And so when we go back to this schema, we see that its mechanism of action and its site of action is on the BCL2 protein itself. It will bind to the BIM binding site, preventing BCL2 from binding to and sequestering BIM, thereby allowing BIM to go ahead and exert its apoptotic effects, leading to cellular death. To date, the translocation 1114 subset in myeloma remains the only subset that's amenable to targeted therapy, and that is with BCL2 inhibitors. And this has been studied in clinical trials. This is a Kaplan-Meier curve taken from the phase 3 Bellini study, where they studied venetoclax in combination with bortezomib and dexamethasone compared to placebo, bortezomib and dexamethasone. And this is the T1114 patients in this trial showing improvement or prolonged progression-free survival in the experimental arm with ven compared to the control arm. And so unfortunately, despite its therapeutic benefit in this subset, venetoclax has yet to be approved by the FDA for use in myeloma, and that's largely been due to increased deaths in the non-T1114 patients due to heightened risk for infection. However, venetoclax continues to be studied in the clinical trial setting. What's interesting about this, however, is that not all T1114 patients respond to venetoclax, and this has opened up a lot of areas of research in myeloma to investigate why that is. So going back to our clinical case, because this patient had a translocation 1114, we went ahead and started venetoclax and dexamethasone, and his M protein level went from 2 grams down to 1 gram after 2 months, which would be consistent with what we would call a partial response to therapy. However, at the 3-month follow-up, we now see that the M protein is going up to 1.5 from 1. So this wouldn't be enough yet to say he has disease progression, and we generally like to see either a bigger jump or 2 consecutive rises in the monoclonal protein. However, unfortunately, at his 4-month follow-up, the M protein now is up to 2.3 grams, which is higher than it was before he started treatment. So this, unfortunately, is consistent with disease progression and requirement to change therapy. And so we went ahead and looked back at his NGS report to see if there were any other targetable genomic findings that we could use. For example, if he had a BRAF mutation, where we could use like one of the BRAF inhibitors. And we only saw this NRAS mutation. And so RAS pathway mutations are quite common in myeloma. And I'm going to discuss why this mutation is particularly important and relevant in the context of translocation 1114 and why it might explain his short response durability. So we're going to switch gears and discuss the biologic heterogeneity of translocation 1114 myeloma. So our lab revealed 12 molecular subgroups in myeloma. And so while this is all one disease, we can see that there is tremendous tumor heterogeneity in this disease. And interestingly, 2 of these subgroups carried a translocation 1114, but they had very different genomic profiles. So the group to the left here in the light blue has this very simple genomic profile where we don't typically see the classic copy number changes or driver gene mutations that we tend to see in myeloma. Whereas the group to the right, also a translocation 1114, has that more common genomic complexity that we do tend to see in myeloma. And so we call these 2 groups CCND1 simple and CCND1 complex. Prior studies, however, by Dr. Zahn, through the use of RNA profiling and clustering, also revealed 2 subgroups involving the CCND1 class in myeloma. And the CD2 group he defined as a subgroup showing this more early B-cell phenotype with enrichment for early B-cell surface markers such as CD20 and PAX5. So we were already, even several years ago, seeing this heterogeneity or differences within this one subset, where not all patients' tumor biology is the same. In an effort to define a better predictive biomarker for venetoclax response or sensitivity, our colleagues at Emory University, Vikas Gupta and Larry Boyce, conducted a study a few years ago where they concluded that among T1114 patients who express early B-cell surface markers, including CD79A and CD20, that the presence of these surface markers correlated better with patients responding to BCL2 inhibitors than the translocation 1114 status alone. And so what we've shown is that T1114 myeloma is a biologically heterogeneous subset that warrants comprehensive genomic profiling to guide precision therapy. And therefore, we employed a study with several collaborators at the University of Miami to basically better define and characterize the genomic heterogeneity of translocation 1114 myeloma using whole genome sequencing. And we also wanted to identify genomic features that were present upfront and predicted upfront refractoriness to venetoclax, as well as genomic features that were selected or acquired at the time of relapse following venetoclax-based therapy. So we had a training cohort consisting of 34 patients from Mayo Clinic, and we had a validation cohort consisting of 21 patients from Ostrava University and from Emory University. We had mostly whole genomes, and we had 10 patients who had paired samples before and after venetoclax therapy. And so, like I said, this was a multi-institutional collaborative effort involving Mayo Clinic, of course, the University of Miami, Memorial Sloan Kettering, University of Ostrava, and Emory University. So during our driver discovery analysis, we identified that T1114 patients who harbored a RAS pathway mutation in one of these four genes, NRAS, KRAS, BRAF, or FGFR3, had a significantly shorter progression-free survival to venetoclax-based therapies compared to the wild type. And this pattern was consistent and also observed within the validation cohort. We then wanted to see whether the RAS pathway mutational status influenced depth of response to the treatment with venetoclax. And we saw that all primary refractory cases indicated in the red harbored a RAS pathway mutation, and that there were far fewer cases of these deeper responses to treatment, such as complete response or very good partial response in the green and the dark green among the RAS pathway mutated group compared to the wild type. And so knowing this and showing this in this study, this likely explains why our patient had such a short response durability to venetoclax, which was largely unexpected because he harbored an NRAS mutation. In addition to identifying these upfront pathway mutations, we also had a few cases where RAS pathway mutations or changes were selected at the time of relapse. And so we had a patient who had a WNK2 mutation. WNK2 functions to inactivate the RAS pathway as a tumor suppressor gene. We had a patient who had an NF1 deletion in this blue here, and NF1 functions to convert RAS GTP to the inactive GDP, also functioning as a tumor suppressor gene. And then we had another patient in the yellow who had a selection for a BRAF mutation, the V640E mutation at the time of progression. Of course, BRAF is an oncogene, and these were all acquired in a clonal manner, which were previously undetectable at baseline. We had some functional studies to validate these genomic findings by Dr. Bergsagel at Mayo Clinic, where he used a T1114 myeloma cell line and engineered it to have this NRAS mutation in a competing assay where these cells were exposed to escalating doses of ven, showing that the mutant NRAS cells outcompeted the wild type and were refractory to all doses of venetoclax. And so what these results show are that RAS pathway gene mutations confer a shortened progression-free survival among T1114 myeloma, and they are associated with an inferior response to venetoclax-based therapies. In addition to the RAS pathway changes, we also found a couple of cases where we had loss of the tumor suppressor gene NOXA at the time of relapse. NOXA is encoded by the gene PMAIP1, and this is how NOXA works. So we're going back to the BCL2 pathway, but this time I'm showing you how the MCL1 works in the BCL2 pathway. So MCL1, like BCL2, is an anti-apoptotic or pro-survival regulator. It's going to bind to BIM, and it's going to sequester and prevent BIM from exerting its apoptotic effects. And so what NOXA will do is it will come in and it will bind to MCL1 at the BIM binding site and prevent MCL1 from binding to and sequestering pro-apoptotic regulators, leading to cellular death and apoptosis. And so this is an example of a patient who had a biallelic deletion, meaning they had loss of both copies of the gene. This is a copy number plot where you see the copy number on the y-axis. The black line represents the total copy number, where 2 is normal. And this is before treatment, showing the normal diploid 2 copies of the NOXA gene. And at the time of relapse, we have loss of both of those copies of the gene, where you see the black line at 0. We had another patient who had a slightly different change. This one had a post-gain deletion. And so here, before venetoclax, we have 2 copies of the NOXA gene. And then at the time of relapse, we now have what we see as actually a gain. And then within that gain, we have a focal deletion. And so our lab also investigated these biologic phenomena in myeloma, showing that these post-gain deletions can involve or tend to involve tumor suppressor genes. And even though you still have technically 2 copies of that gene, we do tend to see a pattern of reduced gene expression with these post-gain deletions. And so luckily we had RNA data from this patient that confirmed reduced expression of NOXA, even though 2 copies were present. Functional work investigating the loss of Noxa was completed at Emory by Vikas Gupta and Larry Boyce, where they looked at 3 different cell lines, 2 with T1114 myeloma cell lines, and then 1 had an NRAS mutation as well. And they performed a CRISPR Noxa knockout in the red, exposed these cells to escalating doses of Ven, and showed overall reduced cellular killing that was most pronounced in the cell line with the concomitant NRAS mutation. And so these results show that even loss of Noxa can be selected at relapse in Ven-treated T1114 myeloma and can be an acquired form of venetoclax resistance. So in summary, we've shown that T1114 myeloma is a biologically heterogeneous disease and that not all patients benefit equally from BCL2 targeted therapy, that venetoclax demonstrates activity in T1114 myeloma, but resistance can still arise through these genomic events such as loss of Noxa, that RAS pathway mutations and loss of pro-apoptotic genes such as Noxa are key genomic mechanisms of resistance, and that the power of comprehensive molecular profiling is really essential to guide personalized and precision treatment and medicine approaches in relapsed multiple myeloma. And so, of course, I'd like to thank all of our sponsors. I want to thank the Cancer Center and, of course, the Myeloma Institute that Ola has built from the ground up for their unwavering support in me and in supporting my research and all of my endeavors here at Sylvester. I'd like to thank the Multiple Myeloma Research Foundation for sponsoring or funding this study through the Research Fellows Award, and of course the K-12 program for the support and also funding this study. And first and foremost, I'd like to thank all of my mentors, Dr. Ola Landgren, Dr. Francesco Mora, all of our wonderful collaborators at all of these great institutions. But the biggest thank you always goes to our patients for donating their samples so that we can advance the science and learn, and with the goal of course, improving survival and treatment outcomes. Thank you so much for your attention.
Thank you, Dr. Kaddoura, for sharing that very exciting work with us and understanding the molecular basis for recurrence of multiple myeloma. Bringing it back to the clinical realm again, the laboratory studies are extremely interesting. But how well tolerated, though, are these drugs, specifically the bispecific drug that you mentioned, because given the fact that there's going to be recurrence and so forth, as the quality of life of these patients truly improved, even for a short period of time when given these medications?
Yeah, so with the bispecifics, most patients tend to tolerate them quite well. We always have to be on the lookout for what we call CRS, or cytokine release syndrome, which we monitor very closely, especially when patients start the drug. And currently, all patients at need to be hospitalized when we start these drugs to employ a very safe ramp-up dose to monitor for cytokine release syndrome. But with my experience and with what I've seen, most patients do tend to do very well in terms of quality of life. They can have a few side effects, but the real nice part of these drugs and most myeloma therapies is that they can be given outpatient. And that's different to what we can give in leukemia and even in some regimens in lymphoma. And so if patients tolerate the bispecifics well, they don't have this, grade 3 cytokine release syndrome. This is given as an outpatient, and we've even started looking at de-escalating the frequency with which we give these. And, they work pretty well in these patients.
Thank you, Dr. Kaddoura. Thank you for that presentation. Timur, let's go on with our next speaker.
Lovely. Thank you so much for that, Dr. Kaddoura. It's my honor to introduce our second speaker for today, Dr. Agarwal. Dr. Gauri Agarwal is the Associate Dean for Curriculum and Associate Professor of Medicine, Medical Education, Health Data Sciences, and Informatics at the University of Miami Miller School of Medicine. She also serves as the Course Director for the Medical Education Senior Elective. She obtained her undergraduate and medical degrees at the University of Miami as part of the 6-year honor program in medical education. She completed residency training in internal medicine at Northwestern University and the University of Pittsburgh, where she also served as chief medical resident. She has been on the faculty of the University of Pittsburgh and Harvard Medical School prior to returning home to the University of Miami in 2007, where she has been inducted into the Gold Humanism Honor Society, Alpha Omega Alpha, and the Iron Arrow Honor Society. She has developed, directed, and taught numerous courses at the medical school. Dr. Agarwal has an interest in the medical humanities and founded Obliterants, the medical school's first humanities journal. She serves as the faculty advisor for UM's chapter of the Gold Humanism Honor Society. She has won many school, regional, and national teaching awards, including the ACP Medical Educator Award. In 2017, she received the Leonard Tao Award for Humanism Medicine. Nationally, she chaired the Cell Biology and Physiology Item Writing Committee for the National Board of Medical Examiners and has led national board review courses for practicing physicians for the ACP. Her research interests are medical education, interprofessional education, and medical humanities. She has published research on the impact of visual art training on medical education and presented her work globally at the Association for Medical Education in Europe International Annual Conference. In 2023, she was one of 2 faculty members nationally to be a Gold Humanism Scholar for the Harvard Macy Program for her work in developing a curriculum on the intersection of artificial intelligence and the medical humanities. Please welcome Dr. Agarwal.
Thank you, Timur. Thank you, everyone, Dr. Weiss, Dr. Taldon, for having me here. I'm going to go ahead and share my screen. I'm afraid this topic is entirely different than what we've just been hearing, but hopefully we'll give you some global perspective on some of the things that we're doing at the medical school. Okay, so I want to actually start with a couple of quotes from some of our technology CEOs. Sam Altman, the CEO of OpenAI, recently said, "In a decade, perhaps everyone on Earth will be capable of accomplishing more than the most impactful person can today." And Demis Hassabis, in a recent interview, he's the CEO of Google DeepMind and was awarded the Nobel Prize in Chemistry, feels like we might see the end of all disease. I think that's within reach, maybe within the next decade or so. I don't see why not. So our technology CEOs feel like we're on the verge of a creation of a new version of humanity that's disease-free and with boundless capacity. I promise not to make such grandiose statements today, but I think it's fair to say that in the next 5 to 10 years, all of us are going to come to a reckoning of what are those essential features and roles that we will provide as physicians, what's irreplaceable, and what could be perhaps enhanced by artificial intelligence. I want to share, these are AI-generated images. Here's another one. My current AI image generator seems to think that a stethoscope doesn't require earpieces to hear the heart or lungs. So I think we're safe for now. There are still some limitations to these tools, as we can see. But this question of our evolving roles has really fascinated me, and it led me, to think about what we need to teach our learners, our residents, our students, even our faculty. And this came to the formulation of this project called the HUMANN Project, and how we can use perhaps the medical humanities to reflect on these tools. The technology is continuously evolving, as we all know, and so rapidly evolving that we can't really just teach the technology. We have to think about how to make sure that our students, our trainees can evolve with the technology and learn how to integrate it and reflect on their very uniquely human skill sets. Some of you may be familiar with this particular painting. It's called The Doctor. It was painted by Sir Luke Fields 100 years ago. And it was painted at the time when physicians weren't viewed very well in society, but it's come to symbolize the commitment of physicians to their patients, the empathic physician and the physician-patient relationship. And you can see that this doctor is leaning forward with complete focus on this young, sick, ill child with some worried parents in the background, and the light is completely focused on these two, and the physician has his eyes entirely trained on this young child. I want to contrast that to this other image you're about to see, and this was published in JAMA, and this is in a piece by Betsy Toll, and it was handed to her by her pediatric resident. A young child in his clinic had drawn this image and handed it to him, and he was quite distressed because, as you can see, his eyes are entirely averted from her, her family, her siblings, and staring at the computer and the electronic medical record. So she wrote, as medicine evolves, course, we all need to embrace technology to help us consolidate, organize data, communicate with our colleagues for the benefit of patients and ourselves. But if we lose the human connection in that process, we'll have done untold damage to our profession. It's what our patients want. It's what the sacred trust that drew so many of us to this work. And we all have to speak loudly and clearly with a unified voice to address the dehumanizing trends in our profession and insist that if we are moving towards technological reform, that we're not left with a nation devoid of physician healers. And she wrote this in the age of the electronic medical record. And now in the age of AI, I think we all have to pay very close attention and think about every tool and its impact, not only on our patients, but on us, because we all know some of the negative impacts of the electronic medical record on our own well-being and other effects that it's had. So today, I hope to talk about how the humanities can help us reflect and find these distinctions about what is human and what could be best enhanced by technology. I'm going to talk to you about a very evidence-based strategy of the humanities called visual thinking strategies, if you're not familiar with it. And then I'll talk about how this all came to a head and we melded our technological curriculum with our humanities curriculum to deliver something for our medical and nursing students. So as I was thinking about the curriculum, I saw this particular article. It was an article from Eric Topol, and this image really caught my attention. He was trying to link the presence of the physician and the other members of the healthcare team in the room at the bedside and trying to connect it to how we've seen automation evolve in cars. And there's stage 0 automation, that was when cars were first developed, to the point where we are at stage 5 full automation, where we technically don't need a human being in the driver's seat. Will we get to stage 5 automation in this healthcare delivery that we are planning in the next few decades? How willing are we to disappear in this equation? So there's a wonderful piece from the National Academy of Medicine that was called The Hope, the Hype, the Peril of AI. And particular to medical education, it said AI will not replace providers, but providers who leverage AI will replace those who do not. So there is absolutely a need for training in AI for our learners and our faculty. And there's also a role for AI in training those medical students and other trainees. So we all have to really be very comfortable with these tools ourselves. We need to partner with AI experts within our health system. We have to develop ourselves and others. It's critical because we need to talk directly to our trainees about their very real concerns for job loss, threats to the traditional role, bias within these systems, the black box within these algorithms that leads to lack of transparency. We need to be comfortable having those conversations. So I'll tell you a couple of examples how AI is being used in training. And we've been using it in admissions. And on the left, you'll see an image, which is from a comprehensive BEME guide of scores of medical education publications that have talked about how AI is being used in medical education. So it's being used in admissions, UME and GME, to do things like looking for bias in letters of recommendation or scoring letters, predictive models for who gets an interview. Our students are certainly using it to generate practice questions and personalized tutoring, to practice their own communication skills and clinical reasoning. We use it daily, right, in research and management algorithms. But as a curriculum person, thinking about the density of what we already have to teach our learners, it became very important that we all try to think about delivering training in a way that it's linked to existing content. So I'll give you an example. Dr. Lina Shahade, one of our faculty, was able to actually integrate the use of this tool, Glass AI, into a case-based collaborative learning session that was teaching about critical thinking. So the students generated their own differential diagnoses. Glass AI generated a set of differential diagnoses. They compared and contrasted and reflected on the changes and differences. And we are certainly trying to enhance precision education of our learners, individualizing training and assessments. So as an example, the Gordon Center, they're working on feedback using video analysis of learners and particular rubrics to personalize and automate feedback to our learners. Dr. Adrienne Reynolds and Dr. Marie Maloney recently received a grant from the AMA to work on a chatbot, an AI chatbot for coaching learners. So there are many things that are happening on the back end in medical education. But what I was really interested in is how do we train our learners in AI itself? And there's this particular paper on AI education for clinicians, and a lot has been written, but what struck me about this particular table was we can think about it as levels, right? So a basic level of training would be making sure that our learners are able to practically use the clinical AI tools that are out there. A more proficient learner would be able to not only use them, but reflect on the ethical implications of these tools or critically appraise these tools. And then really an expert level of understanding would pair up clinical expertise along with technical expertise so that you could actually develop these tools. So at what level? And I certainly want our students to be proficient so that we're practically able to use these tools, but also critically reflect on the ethical implications and critically appraise these tools. And embedded within this article was this quote that medical education needs to focus not only on AI literacy, but very important relational skills like empathy and communication. So I think the question really that boiled down to me is, what are those innately human skills that we provide? How will our role evolve? How do we teach this to our students? And I want to just share a brief story with you that's personal. And I was thinking about this from the vantage point of as a patient and not as a physician. I have 4 children, and 2 of my children are twin girls, and one of my daughters was breech. And I had a wonderful relationship with my OBGYN. I had many conversations with her about my wishes, and I was hoping to avoid a C-section. She was aware of that and why, and I trusted her judgment. So we made a decision to deliver in the operating room just in case she needed to convert to a C-section. And my first daughter came out seamlessly, and my other daughter didn't turn, so she remained breech. And she looked at me, and she was trying to figure out what I wanted to do. And in the moment, of course, I wasn't able to really contribute to my own management. And she just looked at me, and she made a split-second decision. She was weighing multiple factors: the size of the baby, the fetal heart tone. She was thinking about all the conversations we had. And she looked at me and she said, "You've delivered 3 children. Go ahead and deliver this baby breech and push." And I pushed, and my last daughter came out. And what was so stuck in my head was how much she was doing of what physicians do daily, right? She was tolerating uncertainty in that moment. She was using her good judgment. She was solving a new problem. She was reasoning and interpreting and adjusting and respecting my wishes. And she understood what I wanted. And we do this daily for hundreds of thousands of diagnoses. And I completely trusted her in that moment. And I felt very heard and respected. And it's hard for me to imagine any robot being able to simulate that degree of respect and understanding and empathy. So I came to read 2 additional papers, one from The Lancet, one from Academic Medicine, and it gave me a lot of hope. So The Lancet, I'll read you this particular quote: "Paradoxically and optimistically, integration of AI tools into the daily practice of medicine can be adapted to increase humane and compassionate care." So maybe I was asking the wrong questions. It's not so much about replacement, but how do we integrate these technologies so that they can be a co-pilot, a co-intelligence, so that we can relegate some of the drudgery of the day-to-day and really be more at the bedside. And so academic medicine said, as those cognitive skills are effectively and efficiently delegated to technology, we, medical educators, must enhance our training of the non-cognitive, critical human skills that we're all going to need to relate to patients and relieve their suffering. And this is what led me to the humanities. And this is a very evidence-based protocol that's been developed over decades called visual thinking strategies. It's something we've used at our medical school for a number of years. And it was developed by a cognitive psychologist and a museum educator. And it's very simple. You take a piece of art and you take a moment just to look at whatever that piece of art is. And the first question is very intentional. It's what's going on in this picture, image, sculpture. And that question is intentional because you're not just saying, what do you see, which would just pick up details, but you're trying to create an impression, a narrative, a story. And the second question is, what do you see that makes you say that? So that's a critical thinking question, the evidence that you have for what you're saying. And then that final question is, what more can we find to continue the conversation? So as I said, we've done this for a number of years with our medical students. We recently published this AMY guide about implementing these types of programs in health professions, schools. And there's a great deal of evidence about what it does to provide insight into the human condition, human suffering. And the person next to you staring at a piece of art could have an entirely different perspective on that piece compared to you. So it allows us to be cognizant of our own biases and our worldviews. It certainly enhances skills of observation. I'm going to show you a study that we did here. And there's a great deal of analysis and reflection. And medicine is not black and white, and art is not black and white. So it really enhances that tolerance of ambiguity. There's no clear answer at the end. Certainly, it's enhancing their ability to communicate their thoughts effectively, listen closely to the ideas of others. And it's also been shown to improve well-being, just taking people out of the clinical environment into a beautiful space. So this is a study we did with first-year medical students. And I knew that this was powerful because in this particular study, we just took first-year students. We had a cohort of students who underwent the VTS training and those who did not. We exposed them to EKG, chest X-ray, physical exam images. And after the intervention, not only did they write more, they also spent a lot more time looking, analyzing, describing. And then we did a qualitative analysis, looking at whether those observations were actually clinically relevant, and they were. So this was a really interesting to us, and we wanted to incorporate more into the curriculum. And I also had some questions in my head as developing this AI curriculum. Well, what could this do in teaching students to reflect on their own humanity? So you're staring at a painting that has been used in several VTS sessions. It's a painting by Kehinde Wiley. It hangs at our Low Art Museum. And often when we have our very human medical students look at this image, they often talk about themes of representation, inclusion, belonging in art. And of course, the beauty of the image itself. It's hanging in the Renaissance gallery and with the beautiful floral designs around it. So I uploaded this image to ChatGPT, and I went through the VTS methodology. I said, what's going on in this image? And it gave me a great deal of detail, and embedded within that was a judgment. It said, one hand is raised, perhaps that's a peace sign. So I asked that second question. What do you see that makes you say that that hand is a peace sign? And it was able to tell me the reason. That's a commonly recognized gesture. It's two fingers spread apart. And then I said, well, what more can you find? And it gave me a great deal: the style, the color, the flowers, the jewelry, etc. And I worked with it for about a half an hour, continuing in the VTS methodology, and I made a word cloud of all the things that came out. But not once did it start to talk about any of those themes that our very human medical students wanted to talk about. And so what was that disconnect? What was it that it was missing about our very human sociocultural context and the conversations that are in our mouths in the human world? So I found this question interesting. So we decided to create a curriculum that combined these technological skills that we wanted our students to learn, but also melded with the humanities. So the first step was to create a pre-learning online module that would give students the fundamentals. I'm going to play you a video. This was just published in MedEd Portal for other medical schools around the country. And essentially it begins with a pre-test, so students could see where their background knowledge is. And then you get a lot of definitions and core foundations in AI and virtual reality. But more importantly, they learn a lot about how it's being clinically deployed with real-world examples and how it's being used in medical education. And then the fun part was we took videos of people from our own health system who could talk about how they're using it, like Dr. Hatsisi's in cardiology, and several of our radiologies contributed what they're doing in their world. And Dr. Rakour at Bascom Palmer talked about how they're using it in the training of their learners. Dr. Hartley from physical therapy, our own Dr. Taldone spoke about the use of this in the clinical encounter. And then I had a conversation with Dr. Goodman about the ethical implications of these tools. And most importantly, we wanted them to be adaptive and evolve with these technologies. So we gave them tons of resources to stay up to date and different tools for them to play around with. And it ended with a post-test. So that was our pre-learning module. We created a number of different assessment tools, most importantly, a narrative reflection survey. And then we engaged them in an in-person workshop. So after this learning, they came into the Low Art Museum and they played around with AI tools, including a lot of large language models with faculty from our College of Engineering. And they talked about those things like bias and lack of transparency, the hallucinations of these tools. Then they spent some time engaging in virtual reality and AI-generated environments and thought about how it could be used in their future training. And then they engaged in a VTS exercise and also created some art. And then we surveyed them with a few narrative reflection questions. Here are a couple of pictures of our students using VR, creating art, using the large language models and image generating tools, and engaged in VTS. So knowledge was gained, their pre-test scores went up. But more importantly, when they were asked this question of where they thought AI could enhance the care of a patient, they said things like dictating notes, medication interaction, scheduling. Those are the very things that I think we would want to relegate to AI. And then this next question of where do you think only a human being could enhance the care of a patient? And they gave things like delivering news of death, conducting the physical exam, comforting a patient, counseling them, reading body language, physical touch, advocacy, support. These are the very things that I appreciated about my physician. And there's a final question, what do you think are your innately human skills that will not be replicated by AI? And they brought up these kinds of things: empathy, compassion, human connection, adaptability, reasoning, etc. And when I'm talking about, these are the things that, fundamentally they felt could only be delivered by a human, we can also actually use AI to enhance our very human skills, because not all of us are good at these things. So I wanted to show you a couple of examples of more recent work. We just received a meta grant with this company called Body Swaps, where our students could potentially, in the VR world, actually practice empathic communication. So I'm just put a couple of images here of this patient, and you can get some instantaneous, and all the conversations AI generated, so a student can do this on their own. And it gave me wonderful feedback about paraphrasing, how well I summarized my empathy, open-ended question. And in the VR world, it can also give me feedback on my eye contact, if I'm actually paying attention to my patient, and my overall body language. So this could be a very powerful tool in enhancing those very human skills. And most recently, this just got accepted to the New England Journal of Medicine AI. This was another student who, after this workshop, was inspired to think about this distinction about human versus AI in the humanities, and she was interested in ethics. And what we essentially did was we took a number of large language models and we thought of some futuristic ethical scenarios that haven't really been thought of yet. And we inputted these scenarios and we compared the output from the large language models to Dr. Goodman, who is a world-renowned expert in AI ethics. And it was really interesting, some of the output. So as an example of one of the cases, in the future, it's possible that a patient could have an AI chatbot that is their only companion, no family or friends, and they've been communicating with this chatbot about their end-of-life wishes. Is it okay if that patient designates their AI chatbot as their surrogate decision maker? So we asked every large language model, and every large language model was insistent that absolutely not. A human needs to be in the loop in these types of decisions, whereas Dr. Goodman felt that absolutely it could be used if a chatbot could be interrogated to show that it reasonably represents that patient's wishes. It could very well be used for end-of-life decision-making. So these interesting questions are emerging, and if you're interested in more, it'll be coming out soon. So I think everyone knows how historically disruptive AI has been to healthcare and will continue to be. So we have to put it into the curriculum for our faculty as well as our learners. But we have to think very carefully about what I was talking about in the beginning. What are the potential risks of every AI tool we use? Is it going to help us enhance the care of our patient? Will it take our eyes away from our patient? And what are the benefits? Will it take over some of the drudgery that we would like to relegate to technology? And the humanities have proven to be a wonderful tool for that reflection, particularly in our students. And we all need to think about what is that fundamentally human piece of us that will be irreplaceable, and how are we going to continue to integrate this technology into our lives? I want to thank a very large team. We've worked with people from College of Engineering, physical therapy, nursing, the Art Museum, virtual reality, and the Gables. So I definitely want to thank the entire team, and a couple of references. And I'll stop sharing to see if there are any questions.
Thank you, Dr. Agarwal, for that very interesting and provocative presentation. You flashed on the reference list very quickly. I certainly couldn't get it, but perhaps we can put it in the chat or have it circulated to the participants on today's call. So maybe I can start with the first question, and sort of not to put you off base or anything, but does AI have a soul?
That is a deep question that is under significant debate. And I think probably based on your unique spiritual beliefs, you have a different answer to that. Personally, I don't think so. I feel like these are human-generated algorithms that have started to evolve into more algorithms. To me, that's not the definition of a soul, which is, I think, fundamentally human, right? Which combines a lot of things like our essence, essential beliefs, our spiritual beliefs, our core of how we think about the world. It's hard for me to imagine that there's anything even akin to that in an algorithm, but I'm open to debate.
Thank you. Well, I see no other questions. I want to thank everyone for participating in today's grand rounds. It was very enlightening for both our speakers, Dr. Kaddoura and Dr. Agarwal. And I remind everybody to look at the chat for the link for CME and MOC credit. And this was an unusual week where we didn't have a hybrid presentation. Next week, we'll go back to our hybrid in-person and Zoom meetings. I wish everybody well, have a safe and wonderful day, and thank you all, our presenters and participants.
Thank you.
Thank you.